Hi, and welcome to the Mastering Your Fertility podcast. This show is all about reclaiming health, enhancing fertility, and preparing for pregnancy. We're Dr. Haley Nye and Kristin Cornett, your hosts and the creators of the online fertility platform, Tiny Feet. All right, welcome, Dr. Jordan Robertson. Thank you so much for being with us on the Mastering Your Fertility podcast this morning.
Thank you so much for having me.
Yeah, this is going to be fun. So let's just start with you telling us a little bit about your background and why you decided to become a naturopathic doctor.
That's a good question. Actually, the running joke in my family, so my background is actually in critical appraisal, we call it. So where you study medical literature and you decide what's real and what isn't real and how to read studies and discern what's like actual fact and what's myth. So that was my background in undergrad. But as I tried to decide how to turn that into a career, my stumbling on naturopathic medicine was actually just a really long Google search. So I plugged into the search bar, which this is the irony, all the things that I was interested in, which was nutrition and preventative medicine and endocrinology and women's health and exercise. And when I hit enter, the open house for the Canadian College of Naturopathic Medicine came up as the first ad, and then it kind of went from there. So my very research-oriented brain actually just did a Google search, kind of in desperation, trying to figure out how to marry the things that I was interested in, because I couldn't seem to find that when looking down sort of the path of conventional care. And so I looked at whether I wanted to be a midwife, which was a very strong contender at the time, whether I wanted to do things like paramedicine or emergency care. And then I actually just stumbled upon naturopathic medicine, and it became a great fit because it lets me sort of work in that realm of like research and critical appraisal, because the amount of research we have for integrative medicine is really profound, but also lets me keep sort of that sort of education role with patients, which I love, because I have the time, right? And the luxury of being able to like invest in cases in a way that I wouldn't have if I worked in a conventional medical model.
Yeah, that's definitely true. One of the things, of course, that we love about naturopathic medicine. So you wrote a book about pregnancy loss, and one of the areas that you focus on in your practice is fertility and miscarriage. So tell us what inspired you to ultimately write your book.
Well, it actually was my personal history with miscarriage that prompted the initial collection of research. So I had 3 miscarriages before I had my son. So I was pregnant every time that I ovulated in a year period of time. And my experience, like after the third, the first one specifically was quite a traumatic miscarriage that was missed, and lots of ER visits and lots of sort of what I'll call emotional trauma around that. But they all happened like at very sort of stressful moments in my life. They were all in my last year of my naturopathic schooling, during my board exam prep. And when I had the third, I finally was like, okay, well, what's going on here, right? Like how do I, with, the amount of knowledge I have coming out of school, not know how to make this happen for me, right? Like I must be missing something to not understand why I can't maintain a pregnancy. And so it started to evolve into me doing some research initially for myself. I had to really advocate to get progesterone suppositories for my 4th pregnancy, which ultimately ended up being my son. I had to, advocate for the kind of screening and testing that I wanted to have done on myself. And so I started to collect this information originally from like a personal perspective, but then started to realize that we actually should be taking a much more proactive and functional medicine perspective when we look at miscarriage. And the thing that sort of lights my brain on fire in practice is when naturopathic doctors have something so vital to offer medical care for women. So things like polycystic ovarian syndrome, things like miscarriage, we have an incredible role to play. And so I got so excited by just the potential for what we could do for patients that I then really started collecting information over an 8 or 10 year period of time that sort of turned into the book, because by the end of it, I had read every single article that was published about miscarriage over a 10-year period, and felt very confident that I could pull that together to help other women not have to go through what I had gone through.
Yeah, definitely. Well, and I think it's so helpful that you collected that information and that it was very evidence-based, because I think that's ultimately what is kind of going to create that bridge between naturopathic and functional medicine and the traditional medical model. So presenting it in that way, I think, is really helpful in, educating other types of practitioners that may not be staying up on some of this research, largely because they don't have time, right?
Right. I have a question too, because when you talked about advocating for yourself to get the progesterone, to get the proper tests done, do you feel like that's changed at all in the conventional medicine world? Or do you feel like a lot of the listeners out there are probably struggling with that same thing? Hence is probably why you wrote the book, to educate them and say, here's what to ask your doctor for. But it just seems like there's such a gap there still. Because in your particular situation, you had 3 miscarriages, which at that time was the definition of recurrent miscarriage, and is when conventional medicine should step in and say, let's do this, this, and this. So I'm just curious to get a little more information about your personal experience and what it was like to advocate for yourself.
Yeah, it wasn't easy because even like I came in with like an incredible bigger knowledge base than sort of the average patient, right? I was a graduate from a naturopathic medical school, sitting in my family doctor's office, asking for a prescription they were very hesitant to give me. And I remember at that time feeling like I shouldn't have to be like banging the door down for this prescription. Like, it's very well indicated. And I was already pregnant, right? So I'd had my 4th positive pregnancy test in 9 months. And I remember just feeling really disheartened that I needed to go to that length of essentially begging for a drug. I mean, that was 10 years ago, or almost 11 years ago now. So I think the landscape of fertility medicine has changed a little bit. I did cite in the book, 75% of all cases where there's some kind of reproductive technology or patients are in a fertility clinic setting are being offered progesterone as part of their care. So there's a huge percentage of women that are now being offered progesterone when they're in a fertility clinic setting. The question is are we getting women into that setting fast enough or often enough? Or are we over-treating women? Maybe some women don't need to be in that setting if they had access to simple strategies like progesterone, like adequate thyroid supplementation. Like, maybe they wouldn't even need to be in a fertility clinic, right? So I think more women are likely getting access to that care. The question is, are we doing that for the right reasons? I'm not sure, right? That might just be a trend that we see because, we see so much reproductive and endocrine issues in women in this generation that we're fast forwarding them into fertility clinics faster. Our age of women even starting to try to have a family is also older. And so women are qualifying for fertility care maybe sort of faster along their process than women had been 10, 15, 20 years ago. So I'm not sure how to evaluate that, but at least we know now that when women are being treated professionally by a fertility clinic, the vast majority of them are being offered progesterone, which is a very positive step, right?
Right. Definitely. Well, especially, given the safety of a drug like that and, the potential benefit as well. It seems kind of crazy that it was so difficult for you to have to advocate for that prescription.
I know, like in hindsight, it blows my mind that it took that much. And thank goodness I was so stubborn, right? Because now I have a, beautiful 10-year-old son as a result of, me being such a hard ass.
Well, it can definitely pay off to take that stance. So I have a question about research. And so in your book, you talk in several places about studies that you'd like to see done, but that haven't been done yet. So do you think that we're behind in our research in women's medicine and fertility? And, if so, where do you think our gaps are?
That is a huge question. I mean, there's definitely a positive, and I hate the word trend, but there's a positive trend towards having more studies published that are looking at fertility and in the way that it maybe, I'm going to say that it should be, right, in a more complex way, where I'll use PCOS. That's kind of the perfect example. Our diagnostic criteria for PCOS used to be incorrect, right? We used to need women to have a positive ultrasound for them, like a ultrasound with cysts, to qualify as being called PCOS. Fast forward 20 years and that is no longer part of the diagnostic criteria. You don't need to have cysts. And so in some ways, the research is getting better and better, right, as we evolve. Is it happening at a rate that I'd like to see? Maybe not. And we probably are missing lots of pieces when it comes to fertility medicine in the research trials. So a great example is just looking at the kind of patients that are in a fertility clinic, right? So women who are in a fertility clinic smoke more, they're more overweight, they eat less vegetables. And so we have a really hard time when we go to study a population that already is maybe slightly less healthy than women that are walking in the community. And so most of the research hasn't, we call it stratified, meaning that they haven't tried to compare women who are in a fertility clinic and who aren't, women who do eat vegetables to women who don't. We have a hard time separating the lifestyle impact on fertility because we're just studying everybody together as a group. I would say the same thing probably happens with miscarriage, and the phrase, that some miscarriages are maybe, quote unquote, supposed to happen, or maybe that embryo can't, develop. And there is a subset of miscarriages that certainly that happens. There's also a subset of miscarriages that are perhaps preventable. And we often lump them together when we talk about them. And so we don't do a great job in the research of making note that there are sort of certain lifestyle factors that would maybe influence how successful that study will and won't be, if that makes any sense. Do you understand what I'm trying to say?
Totally makes sense. Yeah. You see this sort of phenomenon called like healthy user bias sometimes in the research, where you have a population that's having a certain problem, but they're also more likely to do a whole bunch of things that would make that problem worse. And then, you're comparing them to a study group that doesn't necessarily have all of those tendencies. And you're like, okay, well, what is the driving factor here really? And that can be hard to tease out.
Absolutely. And especially when, and I quoted this in the book, there's a study that just looked at healthy behavior habits in women that are undergoing IVF. And a huge percentage of the women still smoked, still drank, and very few of them exercised. And so you're already biasing the information when we know that, like, as a subset, that's what's happening. And unless the study goes out of its way to comment on like the underlying health factors of that patient population, it could really skew the data, right? Especially, thinking about the interactions between alcohol and folic acid, right? Like maybe a study that's done on folic acid would seem not that effective if we give it to women who have a higher baseline alcohol intake. And so it's really difficult for us to try and make those, you have to really read between the lines and really read the full text to make sure that they've accounted for all of the possible bias that they might have. But there's a ton of selection bias in fertility. And there's pros and cons to that, right? Like when we study people who are undergoing IVF, we've taken out the fact that they might not know which day to have intercourse on, right? And when we study patients walking in the community, and I'm sure you guys have in your practices, we can get women pregnant just by educating them about their cycle. When we study IVF, we've taken a lot of chance out of it, and so it can teach us a lot about an intervention. But there's cons to that too, certainly.
Yeah. Definitely. Well, I think it's so difficult, when you're trying to study the impact of diet and lifestyle, to design a study that teases out like one variable's impact. There's so many things that we can do and so many things that we can educate women on that can have such a positive impact on their fertility. And how do we design a study that takes all of that stuff into account? That's difficult, particularly in nutrition, which is my area of expertise.
Yeah, right. Absolutely. It took, and then really because we study things that way, it makes our patient population also want to do one or two things to try and enhance their fertility, right? And so when you give them a list of 5 or 6 things that are positive, they'll say, well, how will we know which one is working? My answer is, well, I'm not sure we care, right?
Yeah, if you get pregnant, who cares?
That's right, who cares?
Right.
If they all show some benefit that is significant on their own, then imagine the impact we can have if we pull them together. Where conventional medicine, we're more likely to take that sort of silver bullet approach, right?
Definitely. Yeah.
Yeah. Speaking of, so when we do have high quality research, like we're coming out with, I feel like more recently, being able to compile a lot of the past research and do meta-analyses and be able to come up with some really good results. But this new research, it's very difficult to actually see that in practice, especially with more conventional medicine. They're a little behind unless you're like at a fertility clinic that is really up on the research and is taking I would say, the approach of applying that research with their current patient base. But why do you think that is? Why is it so hard to actually like translate that research into real life advice or treatments for women?
That's a great question. I think, one of the challenges we face at least in Ontario, is that the majority of healthcare is funded by the publicly funded healthcare system, which needs some rules, right, in order to create structure. And so a great example of this would be thyroid health. It is not standard practice to run thyroid antibodies in women who are struggling with hypothyroidism. And so for women who have secondary infertility, meaning they have one healthy baby and they've had now miscarriages trying to have their second, that step is not taken as part of like regularly funded public health, because that test in their opinion doesn't offer additional information. It doesn't change how they treat women. And so for us, that ends up being an area where we can certainly like expose the maybe possible diagnosis or cause for the recurrent miscarriages. And so on one hand, I understand why medicine needs rules in order to create some kind of construct that physicians can work under. They need to create some kind of standards of care. To develop and to evolve standards of care takes an immense amount of time and research and effort and money, and for us to be like absolutely certain that that new research is relevant, right? And sometimes new research compared to old research is really a drop in the bucket, and we need to gather more information before that becomes standard practice. Being an off public health practitioner, I have the luxury again of being able to apply research as it comes. And so we have the ability to read something and say, you know what, the research actually is suggesting that testing thyroid antibodies for secondary infertility is maybe the best approach or best practice. And so I have that ability to sort of walk outside that box or color outside the lines. But I certainly understand, especially when health is being delivered at the level of public health, they're trying to do the most amount of good for the most amount of people with maybe the least amount of resources, right? But it is challenging to evolve standards of care, because when new research comes out, like just the amount of information that was before it, right? We need those new studies to really outweigh what's been done in the past. So even in the book, I talk about the difference between using desiccated thyroid hormone and synthroid or altroxin or levothyroxine. The reason we can't suggest using desiccated thyroid is just the amount of research on levothyroxine just like monstrously outweighs the data for desiccated. And so I can't, ethically suggest that we would use natural thyroid hormone when maybe we do have a little bit of research that there's no harm. I just can't beat it, right, with the amount of research we have for synthetic thyroid hormone. And so the standard kind of has to sit there until we can be sure without a shadow of a doubt that it's, that they're equivocal, right? Yeah. But it's tough because each individual woman maybe needs someone to be curious enough about her case to look outside the box and start to work outside those public health lines in order to get her the best care, right? Because public health wasn't designed for her. It was designed to treat the mass. When we look at each individual patient, she may need something that isn't, conventional, right? She might have an autoimmune disease, or she might have a unique case that requires us to look at it with like a much more progressive lens than what the standards of care have suggested.
That's a really good point. And I think that just lends to the point that we've mentioned before, is that every section of medicine has their expertise. So conventional medicine or public health is going to have their place and their expertise, but then you also have more progressive practitioners like ourselves that might be able to bring something else to the table that conventional medicine won't be able to. I also wanted to ask the question on the flip side of that, is that speaking of more progressive practitioners, I feel like sometimes they can take research that doesn't have a lot of studies on it, or maybe they might take like one particular study. Let's take an example for like the keto diet, and they show that it's amazing. You lose weight. It's probably studied on men, or maybe both men and women, but not just women, and not just in the fertility realm. And they start applying it to all their patients, saying that you should be on keto. Give us an example of like why that probably is not the best thing to do.
They're just a caloric deficit. No.
Yeah.
You're right. And so, the phrase I try and use, is we shouldn't really look for zebras in a crowd full of horses, right? Like the reason why most women are having miscarriages is probably right in front of us, right? It just requires a really good history taking for someone to care and have curiosity about what's going on with their life. Not every single woman has a methylation defect or has some unique, undiagnosable autoimmune disease that we need to search for. Some women do, and I see those. Some women do. I see them, but not everyone does. And so I think if we go into that sort of assessment, realizing that we need to just rule out, honestly, the very basics, right? If we think about like basic healthcare is not being met for most women: iron deficiency, B12, vitamin D, protein adequacy, exercise, stop smoking, limit the drinking, right? Like these are very simple concepts that 100% of your women would benefit from. Looking for that weird and wonderful needle in a haystack kind of approach for assessment is not necessarily needed for all patients, right? And especially when really good diagnostic testing, and I'm meaning like serum, estrogen and progesterone, FSH and LH. I'm not big on big functional medicine kind of tests like urine steroid hormone analysis. I don't think is necessary. And the reason being is that those tests don't offer more diagnostically than simple, inexpensive, cheap serum hormones. And if I want to be able to have a conversation with a fertility clinic or a doctor, I'd like to make sure that we're all talking the same language. And so I use the same tests that they would use to assess and diagnose their patients. I think when we start to apply treatment across the board, so your example of like the keto diet or whatnot, in some ways that's a bit of a lazy way to practice, right? Like in theory, maybe everyone would benefit from reducing their sugar intake and whatnot, but I don't think that really honors like what's best for the patient in front of you if you are blindly prescribing things across the board and getting really excited and attached to research that maybe doesn't have the kind of like merit that I would want to see. There are not that many studies that have looked strictly at diet and miscarriage, and I like fully admit that in the book. But the couple that we do have, we should cling to because that's like literally the best evidence we have, right?
Right. Yeah. It just reminds me of this patient that I was seeing who is now pregnant, which is so exciting. But she came from another practitioner that told her that she needed to be on a keto diet and needed to stick to like 5% carbs or something really, really low. And I think it was because her past history was that she was having issues with like hypoglycemia, just a really fast metabolism. And, but as she was trying to get pregnant, I was just thinking like, no, that's way too low. 5% of carbs. First of all, it's going to make you so super stressed. Like that is a really hard diet to
I was going to
follow.
say she's too tired and cranky to have sex now.
Yeah, exactly. Like libido just crashed. Like no way she's getting pregnant. So I think, sometimes practitioners can just look at one little piece of the picture and be like, oh, you have hypoglycemia or you're having issues with, blood sugar balance. You need to just go full on keto. And it's like, no, listen, you really got to take, just like you were saying, each individual and look at the full picture and understand what their goals are. Oh, you're trying to get pregnant. Like your goal isn't to completely cure your hypoglycemia for the rest of your life. Like your goal is to get pregnant. So how do we do that in a very safe manner? Exactly. So anyway, so moving on. So with newer, I think we actually already addressed this next question that we wanted to ask you, because you were talking about how in the public health that they don't test thyroid antibodies. So that's just a gap when it comes to what's standard of care and what is current in the current research and what actually needs to happen for women, especially when they're having multiple miscarriages, where we advocate for women to just have their thyroid antibodies tested across the board before they try to conceive to avoid miscarriage. We're all about prevention here, right? So we want to make sure that their thyroid's balanced before. And so speaking of that, like what if somebody came to you and was said, we're trying to get pregnant. We haven't got pregnant before. What are some basic tests that you would run for them?
That's a good question. And so the way that I put it to patients is that lab work needs to tell us something that we don't already know, or it needs to change our treatment. And so if through a history taking, a woman has a regular cycle, she's, either done home ovulation predictor kit tests, or she's tracked her cycle, she's pretty confident she's ovulating, she has minimal cramps, PMS, no breast tenderness. If they haven't started trying, if she's otherwise well and healthy, I may not actually run any tests, right? We certainly can take a incredibly proactive approach, but often applying some of the basic principles for miscarriage reduction, like balancing blood sugar, having vitamin D adequacy. That would maybe be the one exception that I'd love to know that number before a woman gets pregnant. If I'm not suspicious that there's anything else going on, it is very possible that I would run quite minimal blood work. That said, the research over the last year, which has come out since the book has been published, actually has started to define what we think optimal levels of progesterone might be. Where it used to be, we were very happy if progesterone was over 10 nanomoles per liter. We just talked about this before we started, that our reference ranges are different. But in Canada, we used to be happy if progesterone was over 10. That just confirmed ovulation. Whereas now the research is suggesting it probably needs to be over 30, maybe even over 50 to have the lowest risk of miscarriage. So we might actually be starting to get evidence that supports the sort of optimization of female hormones versus just sort of a very black and white approach that conventionally we've taken. But I might not do any lab work to start unless I was starting to get some signs that maybe there is a slightly increased risk for whatever reason. So if in a woman's history she has had lots of Accutane, or she gets night sweats before her period, or she is using 12 to 18 Advil per month to manage her menstrual cramps. Now, this is a otherwise well woman who maybe it isn't completely risk-free when it comes to miscarriage. We might be suspecting some underlying PCOS if she's got, treatment-resistant acne. We might be considering premature ovarian failure if she's got some breakthrough menopausal symptoms. Maybe we're considering endometriosis if she's been self-medicating, with lots of pain relievers around her cycle. And those things would prompt me to do more preventative type lab work to look at what we think is going on, even in this woman who has never tried to get pregnant before. But if those things aren't there, then sometimes I'll have women try to get pregnant for 3 months before we start to investigate a little bit more thoroughly, because like I said earlier, we don't need to be super alarmist about whether or not women are at risk, especially if we address like the pretty specific diet and lifestyle things that will help make every cycle slightly more successful. But the majority of women have some like secrets hidden in their history taking that might give us clues as to what's going on, right? If women have been on the pill like their entire reproductive life, well, why, right? Why did you go on that in the first place? You know, how did that work for you? Did you have side effects from that? Like, there are a lot of things we can tease out from that history that would maybe have us do some preventative lab work. If their mom has hypothyroidism, right? There's things, they have a co-diagnosis of celiac, then I'm a little bit more proactive with the lab work, because I can see that there's maybe some areas that should be more thoroughly assessed before we try and get pregnant.
I think that's one of the things that's so great about naturopathic medicine is the depth of the intake that you do with people, so you can start to really uncover some of these things that might be hiding and would hide from a conventional practitioner that just really doesn't have the time. You know, I always think it's interesting that when a woman already has like a primary care physician and she goes into that person and says, okay, you know, I want to get pregnant now. Is that person going to do like a thorough fertility specific, women's health specific questionnaire or intake with that person that they're already seeing as a patient? You know, probably not. But could we be missing some signs of hypothyroidism? Would we know whether or not her vitamin D is sufficient? You know, would we know exactly what clues might be in her menstrual cycle that might tell us that there could be an underlying hormonal imbalance? And that's just what I love about spending the time to do the intake. And I think some people are so used to living with symptoms that are annoying, but they're not so disruptive that it's like bringing somebody into the doctor to say, oh, there's something wrong with me. And we just get so used to those symptoms that we don't think of them as a problem. And that's what I think is great about doing such a thorough intake, is that you can uncover some of those things. And women are like, oh, I didn't know that it wasn't normal for me to have, you know, excruciating menstrual cramps every single month, or you know, for me to have acne every single month, or for me to want to kill my husband every time I start my period.
Mm-hmm.
So
yeah,
true.
that's such a good point. Like, I think most of that we need to reframe the way we think about women's health issues to say they're common, right? They're not normal. Because yeah, we've uncovered lots of causes of infertility just by doing that great thorough history taking. I can recall a specific patient that, you know, I inquired about her breast health, and, you know, she kind of like casually, I asked her about nipple discharge, and she's never been pregnant before. And she's like, oh, well, just when I work out. Right. I was like, well, what? Like, go back. And so it turns out that she has galactorrhea, right? But it only happened when she had a sports bra on, and she would get the like nipple stimulation and she would have milk let down, but she's never had a baby. And so it was only then, like after having that thorough, she's like, oh, no one at the fertility clinics ever asked me about breast health. And they also had never run prolactin. And so it ended up that was part of her case and something that was getting in the way of her having a successful cycle. And so, yeah, it really you have to go back to like the beginning. And even we're starting to see, and I've spent a lot of time in the last year researching PCOS, women who were born small for their gestational age are at a higher risk of developing PCOS in their lifetime. So I now even go back and ask about like maternal health, and what that pregnancy was like for that woman. Did her mom have gestational diabetes? Did her mom have preeclampsia? Was she born small for gestational age? Because it actually increases her likelihood of having a small placenta, small for gestational age babies, but also all of the risk factors that create increased likelihood of miscarriage. And so my history taking is now even going back one generation because of what we're learning about that sort of epigenetic experience with specifically PCOS.
Yeah, I love that. And I love that we're starting to do a little bit of that research into like the in utero environment and how that impacts the development of that child and how that can ultimately impact, especially for women, what their reproductive years really look like in terms of symptoms and, what their risks are during pregnancy. So I think that's awesome that that you're going back that far. And, I think we asked some questions about like whether or not somebody was birthed vaginally or by cesarean and whether or not they were breastfed. But I love the idea of asking more about what their mom's pregnancy was like with them. That's great.
Yeah, I'm sure it's very fascinating to the patient /
It
client
is.
too, of like, why does that matter?
It
What do
is.
you
And
mean?
so many women don't so many women don't realize that they live their entire life with their eggs, right? And so their health history from the beginning actually will impact their fertility care. Even my daughter, who's 7, came home from school after learning about the female body, and she says, "Mommy, my teacher didn't know that her eggs had been in there her whole life." And so my 7-year-old is educating her teacher that a woman actually lives her entire lifetime with her eggs. And she's like, "I told her my eggs are in there." Right. And so, but even that knowledge
That is
to
so cute.
recognize that the way that a woman's entire health history actually impacts her fertility, this is knowledge that I think is vital for us to pass on, not just to women who are trying to conceive, but also for them to be able to pass to their daughters, right? That, we're getting a little bit of evidence that maybe Accutane lowers ovarian reserve, right? We're getting more and more women being diagnosed with cancers at younger ages, exposed to chemotherapy, who now are trying to get pregnant. We have a lot to learn, I think, about just the way that our environment and drugs and whatnot are impacting fertility for women. But having them understand that, I think, is so key, because they're just missing that knowledge. It's not that they don't want to have good fertility. No one's ever given them a reason to kind of care about it, right?
Right. Well, I think that this sort of hints at an underlying problem in conventional medicine, which is healthcare versus disease care, and how we educate people about what it actually means to be healthy and why they need to spend time investing in preventative care to keep themselves healthy, to preserve health, and then ultimately, for women in their reproductive years, preserve fertility. And I just don't think that we have that mindset. We're very reactive in healthcare as opposed to proactive. We go to the doctor when there's something wrong, and doctors will look at tests and go, okay, yeah, now you're firmly out of range for this. They're not necessarily looking for signs that something might become wrong in the future. They're like, are you out of range? If you're not, then you're healthy. And I think that kind of gives us just the wrong mentality about our health and about our fertility.
Mm-hmm. Yep, you're so right.
Yeah, I had have a patient with premature ovarian failure at age 16. It was primary amenorrhea, which just means she never got her period. And she was put on birth control for 10 years. And she came to me because she wanted to get off birth control because she wanted to get pregnant. And it was just a really hard conversation with her that I was the very first practitioner to actually tell her, you're not going to be able to get pregnant. And that, in fact, you shouldn't be on birth control. You need to be on bioidentical hormones because you have this genetic condition or something happened to where, you have premature ovarian failure, which, her FSH was well over 100 and her AMH was 0. So it was just, there was really no chance. But it was interesting because I had a conversation with her of because she's very interested in wanting to know why, which is totally understandable. And I told her to have a conversation with her mother learn more about how your experience was, or her experience was when you were in utero, and maybe even before, where did she work? Was there any exposures during pregnancy? And it was a really interesting conversation to have with her because it was just she never thought that it could actually be something that her mother was exposed to, that maybe she absolutely had nothing to do with the premature ovarian failure, that it was something that potentially was caused way before she was even conceived or during utero.
Well, it's definitely disappointing that there's so many environmental factors that we, especially obviously as children, when we're in the womb, we have absolutely no control over any of that stuff. And, it's unfortunate that we do live in an environment where we don't always have control over the things that we're exposed to and things that can literally affect the entire course of our lives. And that's a whole other soapbox, but I thought I would just, mention that. That's a different podcast episode.
Exactly. So I know that you wanted to, or in your book, you actually took a pretty firm stance on alcohol and caffeine exposure for women and potentially men as well.
Yeah.
So could you give us a little more background on that and the research that you found?
Sure. Yeah, I do take a firm, hard stance on it. I think because culturally, we take a pretty wishy-washy stance on things that are not healthy, but that are still endemic in culture for fear of disappointing someone or making someone upset. When my role really in writing the book is just to give you information when someone comes to see me and they have a specific outcome that they want to achieve. My role is to give them the best information possible on how to achieve that goal. Whether they go home and do it, whether they go home and hate my guts, that's completely different. But the evidence for caffeine and alcohol is quite compelling. And if we had a drug that did the same thing or did the opposite, right? We jump all over that, right? Being very excited. If a drug reduced miscarriage as much as alcohol caused miscarriage, we'd be prescribing it to every woman in a fertility clinic. But yet, when it's something that's cultural and something that's dietary and something that maybe requires a hard conversation or work on the patient's part, suddenly we're a little shy about recommending it, without a shadow of a doubt. Now, most of the research, like I said, on diet is pretty sparse. But what we do know is that couples that have any alcohol during an IVF cycle, and so this was actually just a short duration, right? They really just track these couples maybe for 4 to 6 weeks prior to their IVF transfer. And women or men who had had any alcohol in that 4-week period of time, their failure rate was twice as high as the couples who abstained from alcohol during the same period of time. We're talking about like a doubling of the failure rate, meaning that people who abstained were twice as successful as people who drank in the 4 weeks. And given that such a huge percentage of patients still drink in that window of time, right, which was found in a different study that was just observing health behavior, if 20% of couples are still drinking in that last 4 weeks, you can't tell me that that's just not an education issue, right? Like I say in the book, right, it's like the biggest effing day of their year. Did anyone tell them, right, that not having a drink for 4 weeks before might double the likelihood of their success? Now, my guess is for women that abstinence longer than 4 weeks probably has a positive impact, given that her egg quality, like we said, is there her entire lifetime. And so she may do better with like low to moderate drinking or less or abstinence before she even attempts to get pregnant. But the research was specifically done on those last 4 weeks. And even just taking it out for 4 weeks had a really profound impact on the success of their IVF cycles. And the same goes for men. We know there's a dose-dependent effect on sperm quality and quantity when men drink. So the more they drink, the lower their sperm volume, the more DNA damage. We know that there's a linear relationship there. The problem with studying men is that we've really underemphasized the importance of sperm quality because most technology just like literally takes the most healthy one and we don't care about the rest. And so if on average they're all crappy, we don't care. But the data is showing that the more they drink, the worse their sperm quality is, which you can't tell me that that's not important, even though we don't have a study on it specifically yet. So that's the most sort of compelling evidence we have for alcohol. The caffeine stuff is a little different. The caffeine kind of miscarriage that's caused is not the same as alcohol. So alcohol in theory is sort of teratogenic, right? Alcohol damages DNA. It hurts the sperm, it hurts the eggs. And the reason you have those miscarriages is because those egg and those sperm are hurt by alcohol. Caffeine is different. So caffeine actually causes miscarriages in embryos that otherwise would have possibly been carried to term. And it's also a dose-response relationship, meaning we don't know if there's a safe level. And so that's why I had to take such a strong stand on it, because I cannot say without a doubt that having like a one shot of espresso is fine, but don't have 10. That's not what the research says. It says any is bad, and the more you have, it's worse. And so the stance I had to take was complete abstinence, especially in that last 4 weeks, because caffeine is causing, blood vessel disruption. It's preventing good implantation in otherwise really healthy egg and sperm. And so that these are couples that would have perhaps carried to term if they didn't consume caffeine. And so my recommendation had to be pretty harsh, because the outcome, if you want the outcome you want, then that's probably what has to be done, right? But I recognize that that's like the not popular vote, right? To come off alcohol and caffeine, but it's important, right? And we have the data that it is like maybe vital to a preconception plan. And I'm a big coffee drinker, so I would be the first person to say if you could have a cup of coffee.
I know, I'm shedding a tear right now.
I know. I just don't think you can. I don't think you can do it safely and have your eye on the prize, right? I used to actually not treat a ton of fertility in my practice, even though I had spent so much time doing the research, because I didn't want to have that negotiation with patients about what best practice looked like, right? I didn't want them to ask me, well, can I just drink for half the month? Right? I don't want to have that conversation. I just want to tell you what the best is. And if you want to go home and do something different than that, that's great. But at least I know, like in my, soul, that I told you exactly what the best evidence was for trying to hit that target. And so I swore off treating fertility for a long time, because the lifestyle negotiation for me was so challenging to do in practice. Whereas now I think, especially after spending so much time on it and publishing the book, I'm a lot more confident to just say, well, that's how it is. And so if you don't want to do the progesterone suppositories, if you don't want to take out your caffeine, that's fine. But you asked me how to not miscarry, and I'm going to give you like my absolute best foot forward. And so for the diet stuff, like it has to be taken out as I drink my coffee.
I know, me too.
Well, when you're not actively trying to conceive, I guess I'm lucky, because I've never really, I like the taste of coffee, but I've never really had like the caffeine addiction. And I used to suffer really badly from anxiety before, when I was sick, before I discovered nutrition, before I discovered, naturopathic and functional medicine, and I couldn't tolerate it. And so I was never really able to develop the habit. So I guess that's lucky for me. I still don't always tolerate caffeine that well.
And way funnier with a cup of coffee.
Maybe I would be too, but yeah, I guess it's not worth it at this point, since I'm still going to be trying to conceive at some point here pretty soon. So, we talked about testing for women who are just coming in proactively and, looking to kind of maximize their fertility and minimize their risk of miscarriage. But there are some conditions and some testing that would need to be done if somebody's already experienced a miscarriage. And so I guess in your practice, at what point do you investigate? After how many miscarriages do you investigate? And then what are some of those first line tests? I know a lot of those things kind of depend on the symptoms of the woman and what specifically she's experiencing, but kind of what would be your go-tos for somebody in that situation?
I think I would probably, and you kind of hit the nail on the head, like it probably depends on the case, but if someone has had one miscarriage, let's say, I would be more interested in running some additional tests. So vitamin D is vital. I like to run a day 21 serum hormones to be confident that they ovulated and that their progesterone production is adequate. Especially if we didn't do progesterone like in their previous cycle where they had miscarried. I will do an AMH in women, especially if we have reason to be suspicious that her ovarian reserve maybe is lower. Also because that gives us some guidance as to how long we can go with natural cycles before we would maybe want to refer a patient for fertility care, or at least start that conversation about whether or not they're going to engage with other technology. I would be interested in running a fasting insulin and a fasting glucose. Many women do struggle with some level of insulin resistance. I would also just do a simple tape measure around the waist, looking at where women are carrying their weight, and maybe have a conversation about the impact of diet and lifestyle, and blood sugar regulation. But a fasting insulin and a fasting glucose lets you do a quick HOMA-IR calculation, which can kind of give you some context when it comes to how much insulin resistance that patient has, or how hard their body's working essentially to overproduce insulin. If they have menstrual cramps, and we're about to sort of go down the line, so for in Canada, for women to get to the point of being assessed by a gynecologist for endometriosis is quite a lengthy process. I would run a serum CA-125, which is a biomarker that we're starting to use to rule in endometriosis. I do that in women who've never approached any kind of gynecological care or assessment, because if we're talking about a 6-month wait to maybe have a laparoscopic investigation, I can simply do a blood test to at least rule in endometriosis if we want to go down that route of looking at that as a possible cause. So those are some of the pretty basic tests that I would do initially. I love a ferritin, especially for women who've had heavy menstrual bleeding, or who've just had regular menstrual cycles for a long time. It's hard for women to stay iron replete when they're menstruating regularly. So I often will test B12 and iron as part of just sort of a general health assessment and workup as well. So that's kind of what it looks like. Sometimes I'll do day 3 estradiol and FSH, especially if I'm curious about ovarian reserve, or if I'm wondering if women, maybe if they're slightly older, or if they're starting to exhibit some symptoms of low hormones or declining ovarian reserve. We'll do a day 3 test as well. So that's kind of like that basic workup that I would send a woman for.
So how about cortisol? Because you mentioned that in the book as kind of
I was just about to mention
relevant. You mentioned it in the book as sort of relevant to every woman, whatever boat they're in, whether it's they've already miscarried or, preconception. And, you talk about your personal story with miscarriages being, in your opinion, very highly related to stress. So talk about cortisol, talk about how stress affects fertility, how it can impact miscarriage risk, and maybe what we should be doing about that as women.
Yeah, so I don't routinely test cortisol, and part of that is that the evidence for miscarriage suggests that if women identify that they have high stress, or their cortisol is elevated, they're at an increased risk of miscarriage from stress. So the blood test isn't necessarily an accurate biomarker. Like it doesn't guarantee that patient is stressed, right? So if they are stressed, and many women identify as being stressed, then I treat their stress, right? So that is as good as an elevated cortisol on lab work. If they don't identify stress as being part of their health, but I see, a PCOS picture, which sometimes has really high adrenal involvement, if they are exhibiting other signs and symptoms, maybe of dysregulated cortisol, so like circadian rhythm issues, or if they work night shift, or if they have, blood pressure issues, something that maybe would make me believe that their cortisol levels should be evaluated, then I'll run that as a test. But I will say that the vast majority of women that I end up working with just identify that they have stress. And technically, according to the research, that's as good as a positive cortisol. So when we talk about it, I talk about the influence of stress on fertility with all of my patients, because for men and women, so even if I talk to the female patients and then this information gets brought home to have a conversation about stress and the impact of stress on fertility, we're wired to protect ourselves, right? And so for most women, their reproductive function goes down if they're stressed. And I would include, high intensity exercise or low calorie dieting, or even the keto diet, right? Like things that put a physiological stress on a patient have an increased likelihood of turning off ovulation. And so for women where maybe we're not sure if they're ovulating every month, I'll throw a cortisol in with their FSH on day 21, because sometimes that can give us an idea of whether or not their stress response is actually turning off their ovulatory function. But I have that conversation with everybody, right? And I talk about how, as you're going through your fertility journey, whether that's with me alone or whether that's with a fertility clinic, that when stress rises between ovulation and implantation, women actually have a higher miscarriage rate. And so that's where I think strategies like acupuncture, mindfulness, bringing in some of those practices so that during that 2-week window that women can at least keep their stress consistent, rather than having a heightened stress response, that their success is actually greater. But I don't routinely test it. And I think it's because so many women actually just identify that they're stressed. And that's kind of good enough, actually.
Yeah, I think, one thing that might help some women, to have the test is to have like the proof on the piece of paper that this is something they need to address. I think for a lot of women, it's difficult. Stress is like in your mind, you're like, well, yeah, that's a problem, but I have so many things going on in my life and there's nothing I can do about it right now. And so I think sometimes seeing a positive, like really high cortisol on a piece of paper might be maybe like permission to slow down and stop and, just deal with that differently and prioritize their stress as opposed to just sort of writing it off and saying, well, that's, too bad. That's just how my life is. It can't possibly be affecting my fertility that much.
True. My problem is when it comes back normal, right? Then I'm like, you still need to do all the things I said, even though your test was normal.
Yeah. Fair point. Fair point. Touche.
I understand what you mean. And I think the way that I frame it for women too is that most of the things we give women gold stars for, whether that's showing up to work or being a great parent or a great partner, she probably would still do some of those things even if her stress was impacting her health, right? So no matter how tired, cold, hungry, and lonely we are, if a saber-toothed tiger shows up, we run, right? And many women's work and exercise and their life is that saber-toothed tiger. And so they can keep running. It's how they feel in those quiet moments that I ask them to reflect on. So when you are quiet by yourself in your room, right? Like, how do you feel then, right? And that's sort of the best sort of perspective I can give women, that stress is impacting their health in the soft areas of their health. It's their mood, it's their PMS, it's their libido, it's their cravings. It's these small little signals that their stress is starting to influence and impact their fertility, not the fact that they can't go to their high intensity exercise or deliver a huge presentation. That's not where it shows up, because we're wired to do that. Right? It's the way they feel when they're alone, right? And I would say if you're crying on your side of your bed in a towel after the shower, your stress is having an impact on your health. Doesn't matter to me whether or not, you just got home from a 5K run, right? That's the part we can do, even under really dire circumstances. It's like the rest of your health that starts to deteriorate. And especially for women, it shows up in their PMS.
I can really relate to that. I think Kristin can too. She's like, you can just see her face. She's like,
yeah. Well, I can relate to that, because my story is sort of that classic excessively elevated cortisol, very low progesterone presentation. And, isn't there some evidence that actually shows that elevated levels of cortisol can actually affect the way that our uterus responds to our other hormones? Which I think is interesting. Any imbalance in the endocrine system, you have one hormone that's crazy out of whack, it's going to affect the way that your body responds to the other ones. But I think that's really interesting, in particular for cortisol and how your uterine tissue might be able to respond to progesterone, for instance, in that luteal phase, where it's so important to make sure that that uterine lining is being prepped properly for implantation. And then you mentioning stress goes up during that period, and, either we don't get pregnant or we have a higher risk of miscarriage. So, yeah. Mm-hmm. So I guess we're probably coming to the end of things here. So we always like to ask all of our guests, what are your pearls of wisdom? What are your pieces of advice for women or couples who are on this journey? What do you want the takeaway to be of today's episode?
That's a good question. I think when I wrote the book, the purpose of it was to almost put back some of that power and knowledge to the woman or the couple to know that there's hope. I think that their actions have an impact on their outcome. That's what I want women to realize when they're working on their health, that the things they do matter, right? And the science actually proves it, right? It's not, it's not wishy-washy. If they do the things that enhance their fertility, they can change their story. And I think that we generally under-empower patients in conventional healthcare, that they are more of a victim in their healthcare experience rather than like sort of an agent of change in their own healthcare. And so when I wrote the book, all I wanted was for someone to have all the information in front of them that they would need to get the best care possible. Half of the book is about things that they can do themselves, and the other half is how to find it in their healthcare practitioner. Which tests do they need? Which levels do they need to look at? Which diagnoses need to be considered? And it was all the information there so that they didn't have to have this repeated multiple traumas before somebody gets interested in their case. And so that was sort of my goal when I wrote it. And I think that my take home message, I guess, is that, they're like small decisions and small changes to your health, actually have a really profound impact. You don't need to do a heroic, crazy, complete health takeover to improve your likelihood of carrying to term. There are small, sustainable health changes, and that's it, that really have a really profound impact on a patient's likelihood of conceiving and then likelihood of staying pregnant. So that was kind of my purpose of doing that, was more of just that I want women to feel like they can advocate for themselves to get the kind of healthcare they need. Because even me, as a naturopathic, a graduate, an undergrad in medical research, I could not get the care I wanted. And so how could I create a tool that gave women the language to actually advocate for that themselves, so that they didn't have to experience that they could sort of stand on my shoulders and get what they need so that they can have the family that they want. That was sort of my goal with writing the book.
That's pretty amazing. Thank you so much for that advice. I was over here just nodding and saying yes, 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 because it seems like that's what the era is right now, is these amazing books coming out, giving women hope, giving them this idea that you do have control and that what you do does matter. And that's what we need in women's health right now. We need that change, that paradigm shift, in order for women to get the things that they want, to be able to get their family that they want. So,
and the empowerment as well. Yeah. I mean, just the idea that you don't just go to the doctor anymore and they just tell you everything that you need to know in your 15-minute appointment, and then that's it. You don't have to do anything else. It's the doctor's job to help you. It's the doctor's job to get you pregnant. Now we are starting to get this shift where women are taking a little bit more control back. And I think that that's amazing. And books like this really help women do that, is that, you don't have to be a Harvard educated medical doctor to understand your body and, to figure out what you need to be healthy. You don't need that. What you need is to just, have the information to say, okay, here are the tests I need. Here's what my doctor can do for me. And here's what I can do for myself.
Mm-hmm, exactly.
All right. Well, thank you, Dr. Robertson, so much for being with us today. We really appreciate all of your knowledge. We appreciate your book. We'll be linking to that in the show notes for the episode. Anything else you want to share before we go today?
I don't think so. Thank you so much for having me. I'm so grateful that there are other naturopathic doctors in North America that are interested in evidence, that are taking the stand that you women are, that just the more knowledge that we can give the public on how to make good, educated health decisions, like that just makes me so happy. So I'm so grateful to be part of that for you, so that we can just reach more women and have an even sort of greater impact. So thank you so much.
Absolutely. We love it. Thanks again for being here.
Thanks, Jordan.